Welcome to the My Favorite Learners podcast, where pharmacology meets real-world anesthesia in a whole new way. Hi, I'm Chloe G. I'm here to shake up how we learn about drugs. No dry lectures, no endless memorization, just real conversations with CRNAs, pharmacology experts, and other healthcare pros who know their stuff. Whether you're a student, a seasoned provider, or just a pharmacology nerd, we're diving deep into the meds that make anesthesia happen. So grab your coffee, your curiosity, and let's talk drugs. Hello, my favorite learners. Welcome back to another episode. It's been a minute. Okay, it's been a summer, but come back to the video on YouTube or on Spotify to see the main update with our podcast. And that is that I had merch made. I have a trucker hat on that says favorite learner so that I can rep this brand and podcast and rep everything that I've taught you guys. And if you want to be able to rep this too, I'm going to drop it online eventually, but I will be at the Boston AA conference in a couple weeks at the end of August. And I'm going to be leaving some trucker hats around the conference on Instagram, videoing me where I'm leaving them so that you can grab one for free, take a selfie in it, and tag me on Instagram. And I think it'll be a fun little scavenger hunt type thing. So stay tuned for that. That is the main update with this podcast. So let's dive into the topic today, which is something that can be very daunting for students or providers because we are not cardiologists. We are not cardiac anesthesiologists. We are anesthesia providers that need to know certain things about EKG that will keep our patients safe. And that is what I'm going over today. If you have a cardiac fellowship as a CRNA or anesthesiologist and want to come on the podcast, please reach out to me because, again, I am not an expert in this topic, but I'm going to go over what you need to know for boards and what I think are the main things that are confusing so that I can clarify things for anesthesia learners or ICU nurses, whoever is listening to this as a learner today. So what we're going to get into first, what is a lead? Before we start talking about ST segments, myocardial infarctions, axis deviations, or other things that make people immediately hate EKG, I think we need to answer a question that almost nobody explains well. What is a lead? Okay, this terminology is really used loosely in the hospital, and it makes it kind of confusing. The lead is not a sticker. Okay, the lead is not the wire. A lead is simply a view of the heart's electrical activity. And this gets really confusing because we call it 3-lead EKG. Why? Because we have 3 stickers. We have 3 electrodes. We call it 5-lead EKG because we have 5 stickers, although those stickers are not technically leads. And with 5-lead EKG, we don't have 5 leads that we're looking at in terms of the pictures of the heart. So again, that's where this nuance comes into play in terms of when we say the word lead, what are we actually talking about? So I hope that clarifies it a little bit for you. But I'm going to use the analogy that I used on a TikTok that I posted, but it's baseball, okay? I'm a baseball mom, so anytime I can use something that personally affects me, I love to do it. So imagine there's a batter standing at home plate, right? Now imagine standing at different places around the baseball field watching that batter swing, right? Whether it's the pitcher, whether it's first base, outfield, everyone is watching the exact same swing, but they're seeing it from different angles. One person might be standing behind home plate, the catcher. Look at me, I know baseball, okay? Someone else may be standing at first base, someone near third, same batter, same swing, different views. That is exactly what EKG's leads are doing. The electrical activity occurring in the heart is the same. The leads are simply looking at the electrical activity from different directions. Once you understand that, EKG starts to be a lot less daunting. I really, really love that baseball analogy for that reason. So a little bit further into this electrodes versus leads debacle. So again, electrodes and leads are not the same thing. The stickers you physically place on the patient are those electrodes. The wires connect to those electrodes, and the lead is the electrical view created using information from those electrodes. So when I say I'm looking at lead 2 isn't a sticker, right, on someone's chest. It is a view of the heart's electrical activity. That distinction becomes especially important when we start talking about 3-lead, 5-lead, and 12-lead EKGs, which, again, I already said, makes that terminology really confusing because 3-lead, yes, we actually do monitor 3 leads in that. 5 leads, not necessarily, although there are 5 electrodes. Okay, I hope that makes sense. If it doesn't, put questions in the comments section of this video or podcast, however you're listening. So why would we need 12 different views of a patient's heart? What's the purpose of a 12-lead EKG? Imagine I take one picture of someone's face straight on, and I made a video about this, but here it comes again. You'd get some information, right? But what if I took a picture from the left? another from the right, another from above. Now you have a much better idea of what the patient's face actually looks like. That's what we're doing with 12-lead EKG. We're looking at the same electrical activity from multiple directions. More angles, more information. And those 12 views can essentially be divided into two groups, the limb leads and the chest leads. So let's talk about the 6 limb leads first. We have lead 1, lead 2, lead 3, AVR, AVL, and AVF. These leads look at the heart in a frontal plane. Think about standing directly in front of your patient. We're looking at the electrical activity from different directions, right to left and superior to inferior. So let's go through them. So lead 1 looks across towards the left side of the heart and gives us a view of the high lateral wall. Lead 2 is especially important in anesthesia, or honestly, anyone that's looking at rhythm analysis. The heart's normal electrical depolarization travels in a direction that aligns really well with lead 2. So because of that, lead 2 usually gives us a beautiful upright P wave. And that makes lead 2 extremely useful for assessing atrial activity and rhythm. So when you're trying to determine, is this sinus rhythm? Are there P waves? Did my patient just go into AFib? Lead 2 is your bestie. We're going to talk more about lead 2 in a minute. Let's go into lead 3. Lead 3 looks inferiorly. AVR, students hate AVR, but don't hate AVR. Okay, it's not AVR's fault. Under normal circumstances, AVR is predominantly negative because the normal electrical vector is moving away from it. Okay, so remember AVR is predominantly negative under normal circumstances. So AVR can actually give you useful information when something doesn't look the way you'd expect. So this is where I'm going to really simplify it because, again, we're not cardiologists. I'm not going into the fine, minute details of these things. But AVR should be negative. And when I say negative, I mean that isoelectric line of your EKG. We all have basic understanding in ACLS, right? So all of us should know what that isoelectric line is. If AVR is predominantly negative or below that isoelectric line, that is normal. If it's not, there's something wrong and we need to potentially investigate and get a cardiac consult, right? AVL looks at the high lateral wall. AVF looks inferiorly. Again, I want you to start seeing groups. Lead 1 and AVL are looking laterally. Lead 2, 3, and AVF are looking inferiorly. We're going to go into these groups later when we talk about ischemia and contiguous leads, okay? And I'm going to do a picture and everything. So if you're feeling overwhelmed, just wait a second. I'll give you a chart. Don't memorize everything yet. It's just understanding where they're looking, okay, which is great to know for boards. So now let's talk about the chest leads. So let's move from that frontal plane that our limb leads give us to the horizontal plane, which is our precordial or chest leads, V1 through V6. I like to think about taking a flashlight and slowly sweeping it across the front of the heart. And I can put a picture right here of where all these leads should go on a 12-lead EKG. You guys have seen it before. It's literally printed on the machine. As we move from V1 towards V6, our view changes. The basic pattern I want you to remember is those V1 and V2 are septal, V3 and V4 are anterior, V5 and V6 are lateral. So say it with me, septal, anterior, lateral. Septal, V1, V2. Anterior, V3, V4. Lateral, V5, V6. And it makes sense if you think about exactly where they're placed across the chest, right? You wouldn't even have to memorize that. V1, V2, near the septum. V3, V4, anterior. V5, V6, lateral. It's literally where they're placed on the chest. Where do the chest electrodes actually go? So I just mentioned this. Now that we know what those leads are looking at, let's look at where the electrodes go. This is something boards love to test on. So V1 is that fourth intercostal space, right sternal border. So again, I have this picture here and you can look at it. And again, it's posted on the 12-lead EKG machine itself. V2 is fourth intercostal space, left sternal border. V4 is fifth intercostal space, midclavicular line. Notice that I skipped V3. I did that intentionally because I don't want you wasting your brain space trying to memorize the landmark for V3. Find V2, find V4, and then V3 goes in between that. Then V5 is anterior axillary line at the same horizontal level as V4. V6 is then that mid-axillary line, again at the same horizontal level as V4 and V5. So V4, V5, and V6 should essentially march horizontally across the chest. And incorrect placement matters, right? If you put an electrode in the wrong location, you're changing the electrical view that you're recording. So it really does matter that we're mimicking these anatomical locations as closely as we can. If you place them incorrectly, it can create abnormalities that make an EKG look different than it should. So What about the limb electrodes? Our limb electrodes are right arm, right leg, left arm, left leg. And here's a high yield boards pearl, okay? The right leg electrode is the ground. It doesn't create one of our standard EKG leads. So it doesn't add an additional lead to our monitor, but it is a grounding electrode. And by grounding electrode, I mean it reduces electrical interference with our EKG. So it makes it a cleaner picture. So what are we actually monitoring in the OR? Let's take this and make it very specific to anesthesia. Because everything I just told you about a 12-lead EKG, are we putting 10 electrodes on our patient when they come to the OR? No. Most of the time, we're using a much simpler monitoring system. And this is where I want you to understand the difference between 3-lead and 5-lead EKG monitoring. And I just made a video on this that describes this a little bit simpler in like a minute and a half. So go over and listen to that at myfavoritelearners on TikTok or Instagram. Let's start with 3-lead EKG monitoring. 3-lead monitoring is primarily about rhythm. I'm asking questions like, is my patient in sinus rhythm? Did they develop AFib? Are those PVCs? Did they go into VTAC? For routine rhythm monitoring, this is perfect. And what lead do anesthesia providers most commonly monitor? Lead 2. And now you know why. Remember what we said earlier. Lead 2 gives us an excellent Lead 2 gives us an excellent visualization of atrial activity and P waves. So lead 2 is an excellent rhythm lead. That's why we love it in anesthesia. So let's talk about 5-lead EKG monitoring. So let's say we wanted more information. I'm not only concerned about the rhythm, but I'm also concerned about myocardial ischemia. That is where lead 5 monitoring becomes valuable because we're adding a chest electrode. And one of the most important positions for perioperative ischemia is monitoring V5. Now we can monitor something like lead 2 for rhythm and V5 for ST segment ischemia surveillance. And that distinction is important. I don't want you thinking that lead 2 and lead 5 are paired because they're actually good at detecting ischemia. They're giving different valuable information. Lead 2 gives us excellent atrial and rhythm information, and V5 gives us much better information about ischemic ST segment changes involving the left ventricle. So when you hear anesthesia providers talk about monitoring lead 2 and lead 5, think rhythm and ischemia surveillance, and that is the goal. When we talk about patients on the unit, right? Usually that brown lead or that precordial electrode, I should say, not lead, that precordial electrode is in V1 position, right in the middle of the chest, right? And the reason behind that is because we are looking at rhythm analysis on the unit. And if you're monitoring in V1 position, that is perfect for that. But when the patient comes into the operating room, we want to monitor for rhythm and ischemia purposes, which is why we do lead 2 and V5 positions and monitor those. Therefore, where you place that brown electrode on a 5-lead EKG, it is basically where you're taking that picture of the heart. And what is our goal in terms of the 5-lead EKG management? Do we want to look even closer at the patient's rhythm? Then V1 is a great option. If we want to look at the patient's ischemia, we would put it in V5. So it is important to know and understand that where we put that brown lead is important for different reasons and make that decision clinically depending on what we're looking at. I had some people ask in the comments of one of my videos on this, they asked, why are we monitoring intraoperative 3-lead then? If these patients are low risk for myocardial ischemia, 3-lead EKG monitoring is a clinical judgment for anesthesia providers. But it would be appropriate if the patient is not at risk for myocardial ischemia. Low-risk patients, 3-lead EKG is standard of care. So now we can actually read an EKG. Now that you understand what a lead is, you understand where those leads are looking, you understand where the electrodes go, and now you understand why we monitor leads in certain positions in the operating room and outside of the operating room. Now we can talk about reading the EKG. Here's one of the biggest pieces of advice I can give you. Don't just stare at an EKG looking for something abnormal. We have to use the same systematic approach every single time. So the basic approach is step 1, we look at the rate. How fast is it? Step 2, we look at the rhythm. What is the rhythm telling us and what does it look like? Step 3 is axis, and we'll go into axis and axis deviations in a minute. Step 4, intervals. Step 5, P's and Q's. Step 6, STs and T's. Step 7, answer the question you ordered the EKG for. And finally, step 8, take one overall look. Does the EKG as a whole make sense with the patient sitting in front of you? For this episode, I want to spend some more time on 2 areas that students commonly struggle with: axis and ST segment changes. So we're going to get into that. But that is I can do another podcast if you comment in the chat about going over these EKGs, and we can put examples up and we can run through those 8 steps together. So just let me know in the comments if that's something that you would want me to do in the future. So cardiac axis. So what exactly is a cardiac axis? Do not overcomplicate this, okay? We are not, again, cardiologists. So let's get down to the very simplistic understanding of what a cardiac axis is. It is essentially the overall direction of ventricular depolarization. Normally, ventricular depolarization travels down and to the left. Why towards the left? Because the left ventricle has substantially more muscle mass than the right ventricle. So the overall ventricular electrical vector normally points down and to the left. And for basic axis determination, you can get a lot of information by just looking at two leads, lead 1 and AVF. So here's the trick. Look at the QRS complex in lead 1. Is it mostly up or mostly down? And when I say up or down, I mean positive or negative compared to that isoelectric line. Then look at AVF. Is the QRS mostly up or mostly down? That's it. Don't worry about the P wave. Don't worry about the T wave. We are looking at the QRS. If lead 1 is that QRS is up and in AVF, the QRS is up, think happy heart. That's a generally normal axis. In lead 1, if the QRS is up and in AVF it is down, think left axis deviation. So up and down is left axis deviation. If in lead 1, the QRS is down and in AVF it is up, you think right axis deviation. So down and up is right axis deviation. If lead 1 is down, the QRS is negative, and AVF is down, or the QRS axis or a QRS complex is negative, that is an extreme axis and sometimes called a northwest axis. If this is the case, something is very abnormal and we have to look closely at what else is going on with this patient. So why does anesthesia care about axis? Okay, so I really want to break it down in terms of what is clinically applicable to us in the operating room. So here's the important part. Usually I'm not changing my entire anesthetic because somebody has an axis deviation, right? Instead, an axis deviation can be a clue. Left axis deviation can be associated with things like left ventricular hypertrophy, left anterior fascicular block, previous inferior myocardial infarction, and those are the main three things that I want you to think of. So left axis deviation, we're thinking LVH, left anterior fascicular block, and previous inferior MI. So it may make you think about this patient and their management a little bit more carefully. Right axis deviation can point you towards things associated with right heart strain. So when you think of right axis deviation, I want you to think of right heart strain. It kind of makes sense if you think about it, right? Right ventricular hypertrophy, pulmonary hypertension, pulmonary embolism, COPD. Those are the things that I want you to think about you need to think about when you think about right axis deviation. Moving into that extreme axis, you should start thinking about significant conduction abnormalities, ventricular rhythms, paced rhythms, or other major EKG abnormalities. So for boards, don't think the axis equals diagnosis. Think the axis is a clue and ask, why is this patient's axis abnormal? And does the underlying reason matter for my anesthetic? Are you going to change your anesthetic based on that understanding? So I hope that clarifies a little bit. That is a very, very simplistic rundown of axis deviation. If you want more details, I may have to have a cardiac fellow or someone who's done a cardiac fellowship on the pod. So leave it in the comments. Now we're going to use everything we've already learned in this podcast about where the leads are looking. Because you start diagnosing myocardial infarctions, you need to understand one incredibly important word, contiguous, which is actually low-key kind of hard to say. I would have to make sure I'm saying that correctly. Contiguous leads are neighboring leads that look at the same or adjacent areas of the heart. So here's how I want you to think about it. Imagine there's a fire in your neighborhood, right? One neighbor calls 911 and says, I see smoke. Okay, maybe there's a fire, but maybe it's something else. But then another neighbor calls nearby and says, I see flames. Okay, now we're paying attention. That's the basic understanding when we're looking at ST segment changes across anatomically related leads. One isolated abnormal lead can occur for multiple reasons. But when anatomically related leads are showing concordant ST changes, that pattern becomes much more meaningful. So let's revisit our groups. And I'm going to put this picture here. And I love this picture because it is color-coded. And I hope for our visual learners, you're able to look at this and get a better understanding of what I'm talking about for our 12-lead EKG. So let's talk about our inferior leads. They are 2, 3, and AVF. Some people call it the boot because in this picture, you see it looks like a little boot at the bottom. They're looking at the inferior wall. So if you're seeing compatible ST elevation across neighboring inferior leads, that gets your attention. In terms of our lateral leads, you can see them highlighted and labeled here in this picture. We have our lateral leads. Lead 1 and AVL give us high lateral views. And our chest leads, V5 and V6, provide lateral views as well. We talked about that when we talked about V1 through V6. Again, we're putting together a picture of what's happening electrically in that region of the myocardium. So let's talk about our chest leads again to make even more sense, and we're reviewing this from earlier. V1, V2 is septal, V3, V4 anterior, V5, V6 lateral. Because the chest electrodes literally progress across the chest, like that flashlight analogy, neighboring precordial leads give us neighboring electrical views. So V1, V2 are neighboring, V2, V3 are neighboring, and so on and so forth. If V2 and V3 both showed new concerning ST segment pattern changes, I'm paying attention. If I see something abnormal in V1 and then something completely different in V4 with normal leads between them, that's not that contiguous pattern that we were talking about. Again, don't interpret one lead in isolation. We have to look for a pattern. So let's bring it back to anesthesia. This is where everything we've talked about comes together, because in the operating room, I'm not usually staring at the monitor every 5 minutes asking, does my patient have a STEMI, right? I'm watching for new EKG changes that might tell me something has changed physiologically. Let's say I induce anesthesia. The patient's blood pressure drops. And suddenly, I'm seeing new ST depression in V5. I don't want you to simply think ST depression equals ischemia. I want your CRNA brain asking, why might my myocardium suddenly not be getting what it needs? Did the blood pressure fall? Which I just said that it did. Is the heart rate too fast? Is my patient hypoxic? Is the hemoglobin low? Did I reduce coronary perfusion? Because now we're talking about that balance between myocardial oxygen supply and myocardial oxygen demand. Your EKG isn't something you're interpreting for an exam. It is giving you information about what your anesthetic may be doing to the patient, or what we're going to try to avoid to do to our patient preventatively, right? Thinking ahead and making the plan. And that's the difference between memorizing EKG patterns and actually using these EKG patterns clinically. Okay, we're going to do two things before we finish. I'm going to do a rapid fire board pearls type of segment. And then I have some questions that people asked on Instagram in a question box that I'll answer as well. So 3-lead EKG monitoring is primarily used for rhythm monitoring, right? This is our rapid board pearls type of discussion. 5-lead EKG monitoring gives us additional information for ischemia surveillance. Lead 2 is excellent for P-wave visualization and rhythm assessment. V5 is an important lead for detecting perioperative ST changes. 2 and V5 as a rhythm and ischemia surveillance. Together, it is 80% sensitive to detecting myocardial ischemia. That right leg electrode is the ground, right? It doesn't create an extra lead that we're looking at. It just decreases electrical interference. V1 can particularly be helpful when evaluating conduction abnormalities and ventricular rhythms. An incorrect electrode placement can create misleading EKG changes. But more than anything, I want you to understand the bigger picture. I don't want you memorizing an EKG as a bunch of random squiggly lines or just rote memorization of what your inferior leads are, right? I want you to understand why we're looking at those inferior leads, and if you have ST changes in them, what that means for your patient that you're looking at on the OR table, or the patient that is coming to you that you're going to have to anesthetize, and what the best option for that patient may be. Every lead is simply looking at someone standing on the baseball field watching the same batter swing. Again, with my baseball mom analogy. When you know where that person is standing, you understand what they're seeing. Once you understand what they're seeing, EKG stops being memorization and honestly very overwhelming. It becomes a story about how the electricity is moving through your patient's heart. And in anesthesia, the final question is always, what is this EKG telling me about my patient? Does it require me to do something differently? Whether that's in the moment, during the case, or again, preventatively before the case even starts, and optimizing that patient for your anesthetic of choice. So let's get into the last segment here, which is going to be me answering questions that people submitted on Instagram in terms of EKG. So someone else asked an easy way to remember right bundle branch block versus left bundle branch block, and the same for right and left axis deviation. So I'm going to make a chart and put it right here to help you. So if you are listening, you can come back to the video and look at this chart. But essentially, left bundle branch block indicates left heart disease. Left bundle branch block is theoretically worse in that way. whether that's hypertension with left ventricular hypertrophy, CAD, heart failure or cardiomyopathies, or aortic stenosis. Bad, bad, bad. Don't love to see it. Right bundle branch block is right heart strain, PE, pulmonary hypertension, right ventricular disease. In terms of axis deviations, kind of similar, kind of not. Left axis deviation is left ventricular hypertrophy, anterior fascicular block, and inferior MI, things that I listed already in this podcast. Right axis deviation is a lung problem, that right heart strain again. So COPD, pulmonary hypertension, PE, and right ventricular hypertrophy. So for bundle branch blocks, the left is left heart baggage, the right is right heart strain. For axis deviations, left ventricular hypertrophy and left anterior fascicular block pull your axis to the left. Lungs and right ventricular strain pull you to the right. So because we're not cardiologists and we would get cardiac involved for our anesthetics if some of these things were occurring, if you have left bundle branch block or a left axis deviation, think left side of the heart problem to oversimplify it. If you're having a right bundle branch block or a right axis deviation, right heart strain, right-sided heart problems. So left side, left bundle branch block is theoretically worse than right. Theoretically. Oversimplification. The next question that someone asked is, what is the most important lead on the 12-lead EKG? This, I said, I have a great answer for this, and it's a non-answer. It depends on what you're looking at. And it depends on if you have I will say this, no one lead is more important than the other. What's most important is the contiguous leads. If you have changes in contiguous leads, whether that's ischemia or infarction, that is important in those contiguous leads. And that's what I want you to take home in terms of what is the most important lead on the 12-lead EKG. It's not one lead, it's contiguous leads. That is the most important thing to remember when looking at 12-lead EKGs for our purposes. Those were the two questions that I got. If you have any more questions about 12-lead EKGs, put them in the chat, message me. I would love to answer them or have somebody with more knowledge on the pod to do a more in-depth EKG podcast. If you know, you know. I'll see you next time. Hello, my favorite learners. This podcast is for educational and informational purposes only and does not constitute medical or professional advice. While we strive for accuracy, medicine is constantly evolving and clinical decisions should always be made based on current guidelines, institutional policies, and individual patient considerations. The views expressed are those of the host and guests and do not necessarily reflect the opinions of any affiliated institutions. Listeners should consult their own healthcare providers before making any medical decisions.